identify two main themes that fill the adaptation framework. The first one is redistribution of existing resources, and the second one is resource pooling and cross-sectional collaboration. And start with the first one, the redistribution. So the first major strategy was this redistribution. At the facility level, strategies included personnel, routine services were pushed to staff other services like the cholera treatment unit, as well as treatment to services and services in the Inequalities for the displaced population, and often they work double and triple shifts. Facility managers had to take hard decisions on which services to prioritize over others. In this example, they shifted the maternity board to save a place in the facility to keep the continuity. We used to shift the maternity services from the maternity block to the antenatal block so that at least our mothers can deliver, especially during this time. And cholera units were established, most of the time in tents, outside the main city, as you can see in this photo, and it require designated staff to prevent infection spread. Water infrastructures were heavily affected, like you saw in the photo from Nadav, due to the cyclones, and made it very hard for communities, especially for the amputees, but also for the people who stay in their houses. The providers had to adapt, saying that they start going around in villages, so we would go to Camp A today and Camp B the following day. And healthcare providers also had to be very creative when it comes to the disruptions in medical supply chain. And I quoted one of the providers that told us that the road was cut off for almost 2 or 3 weeks. I remember we just resorted to using the canoe. We packed the medical supplies in the canoe, and then it was delivered to store in the canoe. And lastly, on the facility level, to prevent the outbreak from the father, health providers had from the lower father they went to the communities and engaged them first to educate them about cholera prevention methods, like cleaning the water and how to prepare food more safely. And then they gave them chlorine to clean the water, then the use of ORS, oral rehydration solutions, and later they encouraged them to take the vaccine. And the second set of adaptations, maybe at a higher level, was to pool the resources and collaborate across different sectors. And collaboration between district officials and NGOs and UN agencies were also crucial for combating this outbreak. UNICEF, for example, deployed cholera nurses that went to the communities that were heavily affected and to the facilities to support them, while other NGOs supported with chlorine to the affected communities, with borehole recovery, and also with logistics support for vaccine campaigns. But I have to say that many of these response mechanisms, they depended heavily on NGOs and international agencies, and outbreak severity and the displaced population created needed exceed state resources and capacity. As one of the providers told us, another challenge is that the government alone cannot manage to implement various initiatives. They also depend on NGOs. We find that they have offices, but they do not have adequate resources for funds to implement projects. They wait for local NGOs or international NGOs to come in with intervention so that they can introduce them to the community. And all of these actions require the activation of cross-sectional and cross-sectional and formal and informal collaboration. Besides NGOs and international agencies, the healthcare provider also engage with communities. So they work with, so after both Cyclone Anna and Cyclone Freddy, most facilities were flooded. And it requires support from the community around them to clean and make them operational again. So community leaders came to the facilities, they dig structures around the buildings, so the flood water will go away. Also, healthcare facilities that we interviewed said how crucial was the involvement of traditional leadership in conducting the outbreak. So chiefs were the bridge between the healthcare facilities and the communities. First, they go to the communities, they explain them about the disease, about its reasons, and how they can prepare better the food and water. And later, they try to they try to enforce hygiene rules and counter misinformation about vaccines. So we had different levels of resource pooling with the community, with the traditional authorities, with the chiefs, with NGOs, international agencies, but also with local government and national government level. So, brings me to the conclusion. So, synthesizing these findings, we conceptualized the idea of 360-degree responders. So, healthcare providers, they function as 360-degree responders beyond the traditional clinical roles. They expand the usual mandate toward beyond facilities, in mobile clinics, in IDP camps, in tents, and in communities. They work beyond their normal schedule shifts to continuous emergency response, that sometimes lasts for months, and almost a year in some cases. But all of this, they move from between clinical duties to be system coordinators, to be resource mobilization officers, to engage with the diverse stakeholders, including community, chiefs, NGOs, UN agencies, and governments. But all of that didn't come without the tools. And we asked what is the cost of adaptation, and what are the trade-offs. And there was an overstretching of the system, and we saw that in the past. We witnessed that with the HIV/AIDS pandemic in Malawi, but also globally, because we all witnessed that with COVID-19 and with the overstretching of the health system and the workforce and the health workforce, with the expectations from providers to treat whatever the cost. And we speak about very small numbers of providers that have to be stretched around different roles in different places and work double and triple shifts. And we saw that adaptation strategies that the provider took mitigated some of the shock, some of the cascading risk after the cyclone, but they also sacrificed the internal steps, like we saw with the antenatal health from the provider quote that I gave earlier. And we saw that without putting efforts and resources into recovery of the health system, of water and sanitation, infrastructure, the situation on the ground remains the same, was a perpetuate condition for future outbreaks. And to conclude, to be the more resilient health system, which is the topic today, we need to formalize these ad hoc lessons like working with chiefs, working with communities, hiring nurses and additional staff, following emergencies, or even before rainy season, because we know that infectious disease more going around winter time. And we know that also all sectors exist in Malawi, which is a significant advantage that we don't have in every country. And I wish that we could see it in other countries, including mine. But it is important to anchor this in systematic thinking about prevention and not just in activating emergency mechanisms. Thank you.
Our next talk is by Professor Negev from the School of Public Health at the University of Haifa. Professor Negev is going to speak about bridging gaps in the world of climate change, health inequalities, and everyday adaptation and natural study.
Can you hear me okay? Is it too loud? Not too loud? Sure. So in the meanwhile, I just want to say good morning and thank you all for coming and making this conference possible. It's really a unique event that is so refreshing and out of the box for all of us. And so thank you for participating. And thank you so much, Professor Nadav Davidovitch and Professor Natan for organizing the health sessions. It's already a tradition, right? We've done it for many years and it's always really exciting and interesting to work with you. Okay, so here we go. Thank you, Shahar, for a really great lecture. So I'm going to talk about bridging gaps in a warming climate, climate change, health inequalities, and everyday adaptation, a national study from Israel. So this is the local perspective, and I really have the privilege and honor to work with Prof. Shapira, who is here. Dr. Natan was a postdoc in the project, and now he has a position in Bar Ilan at the Geography Department. Irit Lador, who is here, and Anat Rosenthal, and Suha Natur. I don't know why. Where is Suha? Suha Natur. I don't know why your name is missing. I'm sorry. We're going to fix it. So this is our research team. on this project. Before I go into the national study, I want to give a global perspective to connect with the conference and with the previous talks. So this is a new publication by Natan and I, where we looked at who is causing climate change and who is suffering on a global perspective. And on the top, you can see CO2 emissions in 2019, so pre-COVID, per country. On the left, you see the map that, on the right, you see the map that you are used to seeing with each country by its size. And you can see that China is right now the biggest polluter per country, but also the US and Russia are not far behind. On the left, you see a Peters projection. It means that the size of the country is not the geographical kilometers, but the amount of emissions. So on a global picture, you can see that the global north is getting very fat because it's polluting, and the global south is shrinking and almost not existing. So you look at Africa and Latin America, and not polluting, hardly any emissions, not causing climate change. If you look at the bottom, this is climate-related mortality per 100,000 people in the same year, and we took this from the Global Burden of Disease database. So this is based on heat-related mortality and malaria-related mortality as proxies for climate change, and you can really see an opposite mirror image with the global north hardly any mortality. Climate change is happening there, but the health systems are more resilient, the society and infrastructure are more resilient, and it does not lead to mortality as much as in global north, and especially in Africa. Look at the sizes on the left. We see that Africa is kind of grown up, as well as India. So basically, we have those who cause the problem and those who pay the price. This is our climate paradox. We went on, in order to understand this better, we used NDGAIN, which is another database in climate change, regarding that assesses the readiness of countries to climate change, including the governance and stability, economic stability, etc., versus the vulnerability, the fragility of health and ecosystems. And we see here a correlation, a significant correlation, basically showing that the countries that are most vulnerable are also less ready, are also least ready. Countries in Africa such as Chad and Somalia, we also have India, and down at the bottom we see that those who are more ready in terms of government and economy are also least vulnerable in terms of society and ecosystems. So also on this, basically readiness is policy. Okay, so also on the policy aspect, we have this north-south gap. Finally, from the global perspective, I said before that China is the biggest polluter per country. But this is not really fair because it's also a country with a very big population. So we went on to look at the CO2 emissions per person. And this is what you see here. So you see a very different picture. Basically, China is still a polluter in the fourth out of 6 categories, but you can see the numbers with much less polluting than the orange and red per person. So you can see Russia, North America, the Gulf, Saudi and the Gulf countries, the Emirates, are polluting much more than others per person. Basically, the oil producers are a part of the problem per person, low population and big emissions. I also want to note that there is another step to the analysis that is not in this paper, but it's important to note, that a lot of the pollution produced in and by the big polluters is not for them to consume. So from the Gulf countries, the oil is brought to Israel, Europe, and elsewhere where we consume it. And also, China is a big polluter, but a lot of it is to produce consumer products for the global north. So even when we look per person, it's not really the carbon footprint of also consumption. So basically, we have a big inequality here that we need to start for. Okay, so moving on to our national study in Israel. Just a little bit of context for those who are here for the first time. Israel is located in the Middle East, which is a climate hotspot. It means that the temperature here is going up faster than the global average, and we're almost 2 degrees above pre-industrial times. And also, it's getting much, much drier, as you heard in the morning. We hardly had any rain last year, and also this year is very dry and expected to be a year of drought. And most of the country is arid and semi-arid. We are in the heart of the desert, the Negev desert. Also happens to be my surname because my dad loves the deserts. And in the 60s, young people in Israel changed their family name to Israeli names instead of the old diaspora name, and that's why it's called Negev. So most of the country is desert. We have a diverse population, about 80% Jews, 20% Arab within Israel, not including Palestine. We have a big center-periphery gap in access to infrastructure and services, even though it's a small country, and a high population density with over 10 million people in just 20,000 square kilometers. In this study, our objective is to investigate climate-related health perceptions and needs, risk exposure, everyday adaptation, and the healthcare system's capacity to address these challenges. And I will go through these variables and explain in more detail. The methods are mixed methods. We are looking at this both bottom-up with qualitative method that Tzur is working on in her PhD with focus groups and is going to present here, and with qualitative methods of interviews with health system professionals in the health system that Davidovitch is working on in her PhD and will present today, accompanied by a survey which I will be presenting, looking at the whole population with oversampling of the Arabs as a minority. And after we do all this studying of the situation and the understanding and perceptions, we are now starting a gap analysis and a policy lab where we will do a process with policymakers to understand how the health system in Israel should adapt to climate change. I'm going to present mainly the results of the survey and some of the focus groups really. Okay, so what we see here is the variables of climate change risk according to the IPCC. And we see them here per region in Israel. So we are in the south, in the Negev, which is the biggest part because it's the least populated, so it's one administrative unit. And what we see here is, for example, vulnerability. This we calculated on age. So elderly are more vulnerable, and of course very young, chronically ill, low socioeconomic, low levels of education, etc. And you can see it's very clear that the periphery, north and south, are more vulnerable to climate change. Second is exposure. We calculate the exposure on how much people are personally exposed to climate. So of course we know, we can look at climate data and see that the whole country is extremely hot and dry. But here we ask people, do you have a private car, for example? If you don't, you're more exposed because every commute during summer, which is very long here, can be dangerous in 35, 40 degrees Celsius. Do you work outdoors, which is also a big exposure? In Israel, about 95% of the housing and offices are air conditioned, so most people who study in school or work in an office and even go to the gym, it's air conditioned, everything is air conditioned, so it's quite easy to escape the heat. But if you work in a factory or agriculture or industry or security and things like that, and you don't have a car, you're much more exposed. And finally, we look at hazards, so exposure to extreme heat, dust storms that we have here, and to floods. And you can basically see that the south is most at risk in any respect, and the northern peripherally is also more at risk than the center. I want to connect climate change to health services through a question that we asked in the survey. We asked people, did you have to cancel an appointment or medical treatment or examination due to an extreme weather event? Basically, did extreme weather events prevent you from getting your health services? Maybe people had physiotherapy, occupational therapy for a kid, a blood test, hearing test, regular health services. And the results are very striking. First of all, in dark green is the unrecognized Bedouin population. So as you were driving here, you probably saw that there is a large population in the Negev desert that lives in unrecognized villages. The Bible there is going to speak about them and their health circumstances. 1 out of 3 said yes, we had to miss an appointment. 1 out of 3 people, and that's today, that's not in the future climate scenario. And these people live because the villages are unrecognized by the state. There are no paved roads, so they have to go through muddy roads. Many of them don't have a car, most women don't drive. So really to go to a health clinic is affected by climate events. Out of the general Muslim national population, 20% said yes, so 1 in 5 is already experiencing these circumstances. And out of the Jewish population, only 6% said yes. So again, we see that the inequalities are striking even depending on individual infrastructure. Do I have a car? Is there a road from my house to the hospital? Because public transport is only available if you're lucky to be connected to it. It's not super great here. And then most people depend on public cars to get their health services. Okay, next we asked about energy poverty. To what extent do you use the following actions to manage the impact of extreme heat waves on the temperature inside your home? You can see here that most frequent use is air conditioner, especially among the Jews. Here the rural Negev Muslims are both recognized and unrecognized. So of course in the unrecognized villages there is no air conditioner, I'll show it for later. Then fan, followed by cold showers, going to public spaces, visiting family or friends, quite a social country, so 1 in 5, or just burying the heat passively and waiting, which is also a substantial amount of the population. If we split this by age, we see that the older adults, 65 plus, those who are more vulnerable to climate change and to extreme heat, because they are more susceptible to stroke or heart attack or kidney failure. They use air conditioner a bit less and fan a bit more. And they are quite similar to others in other home environments and going to public spaces. But when you get to visit family or friends, they drop from the younger adults 20% to the 65 plus about 10%. And of course, when people get older, it's getting harder for them to leave the house, to have social networks, and sometimes they're more lonely. And therefore, we have like an intersectional vulnerability, both being elderly and being lonely. We know that this is a predictor for excess mortality from heat, for example, all over the world. Some data but from the words of the participants in the focus groups, and I'm only going to mention a few because Tzur is going to speak about it in more detail. The health impacts on vulnerable populations. A woman from an unrecognized village said, "It's hot, but we don't have an AC button to press." A little bit on structural barriers. A woman from Ofakim, which is a Jewish town of a low social also in the Negev, said, "I had a medical appointment at the hospital, which is about 1 hour away, and I've been waiting for it for 3 months, but it was so hot, I couldn't wait for the bus, and I called and canceled the appointment." And another woman from Ofakim said, "My mother's house was flooded." This is an example of the lack of trust in authorities that was evident in many focus groups. No one from the municipality helped, but we gathered the neighbors, everybody helped, men went up to put plastic sheets on the roof, and we relied on our local resources, kind of connected to what we saw in Malawi. I would like to give an example from an unrecognized Bedouin village that we visited. In this village, there is a health clinic that was initiated by the community in order to close the gap in access to health services. So basically, the entrepreneurs from the community negotiated with health maintenance organizations until they got a good offer from one of the HMOs, and then the whole village changed. We have national health and security here, I won't go into details, but the whole village changed their membership in a health maintenance organization, and that organization built them a health clinic. So they have access, from the bottom up, they closed their gap, and inside it there is a physician and a nurse and blood tests and everything. But there is the villages are not connected to the grid, there is no electricity. So this clinic works on a generator, a solar generator, which is very polluting and expensive, and sorry, not a solar, a diesel generator, and solar panels which are on the roofs, which are cheaper and green, renewable, but they don't provide enough electricity. So basically, they use these two sources alternatively, and inside there is electricity and there is an air conditioner. But this is also only for people who have to go to the clinic. What do the others do? So we see here on the right, we are sitting here in the shik, which is the traditional central tent in the village where all the men gather. And it's built very traditionally in a way that creates a nice microclimate inside. So the breeze comes in and it's less hot. And the Bedouins know how to live in tents in the desert. And there's like 4 directions wind. And they even installed on the ceiling, not sure if you can see it, they installed pipes with water sprinklers. And so they also have like passive cooling, and it's really, really nice. But this is only available for the male. So from a gender equality perspective, the only women who can go in are female researchers like us, and the women in the village are not, do not have access to this. So when we think about everyday adaptation, which means what people in communities can do by themselves, there is also this perspective in a traditional society. I'm going to summarize and say that we saw that climate change intensifies existing health and social inequalities in Israel, and an intersectoral perspective reveals how age, ethnicity, socioeconomic status, and geography combine to heighten vulnerability. We saw that some groups are more vulnerable than others and also have fewer resources for adaptation or readiness. We also saw in the research that everyday adaptation relies heavily on families and communities, but this is not enough. Structural barriers limit resilience. So what do we do? How do we move from evidence to action? We need to strengthen health systems to ensure continuity of care during extreme events, to address energy poverty and housing conditions as public health priorities, invest in community-based and culturally adapted adaptation strategies, and build trust through equitable policies, inclusive engagement, and responsive government. And I'd just like to finish by thanking the incredible project team, especially Dr. Stav Shapiro, who did a lot of analysis, and the PowerPoint is really a joint collaboration. And of course also Suha, Elif, and Anat who are here, and the others who are not. And to thank the students in my lab who are working on these issues in various contexts. And this is the QR for our lab and publication. Thank you.
Thank you, Maya. So while we set up, our next presentation is by Ms. Tzur.
Okay, so thank you very much. I'm Shelly, and I will talk about a One Health approach to vector-borne diseases in an era of climate change. So this is actually the topic of my PhD that I have just started, and I am very privileged to have these supervisors, and Professor Negev that is here, and Noga Kronfeld-Shor, and Chagai Levin, and also as a consultant, I have Dr. Asaf Hochman. I will talk about them later on. And okay, just a second. It's not working. Okay. Okay, I'll move it from here. Yeah? Okay, I'll do it from here. Okay, so, yeah, it's working? Okay, so we'll start with talking about One Health. So One Health is it's like an approach that tells us that everything is connected. So the human health is connected to the environmental health and to the animal health. And the aim of this approach is to sustainably balance and optimize the health of people, animals, and ecosystems. And so the One Health is like telling us that we, like the people who protect human, animal, and environmental health, have to coordinate, to communicate, and collaborate together in order to do it. So if we're talking about the climate health and One Health, so it actually can disturb the balance between all of them. So with environmental health, the ecosystem can be disrupted, or with the animal health, that wildlife has a stressor rising, or with the human health, that the vulnerability increases. So it requires us to integrate it all to a One Health collaboration. So we're in the Mediterranean area, climate change. So Maya and Rita already talked about it. So we have the warmings and the heat waves and the droughts and the floods. So, while most of the studies before have focused on the temperature, like we see in all the maps of the climate change, like here. So we can see how the more red it is, that the more the temperature is rising. So here you can see an example of the 2024 compared with like 20 years before and the changes. But my PhD consultant that I mentioned before, Dr. Asaf Hochman, he's focusing on other effects like season shiftings. This is a graph from his work. So you can see that the red line is the summer and the blue line is the winter. So you can see through the years like how it expands and the winter is getting shorter. So the seasons are shifting. We have longer summers and shorter winters. And also he is dealing with the tropical zone expansion, the ITCZ that is shifting toward us. And also we know already that heat is linked to mortality and disease outbreaks in the region and in the world. So in vector-borne diseases is a really global challenge, and it is transmitted by mosquitoes, ticks, arthropods, and they pose a severe public health, so mainly in tropical or subtropical regions, of course with a population that is more vulnerable, like we talked before. So it comprises like 17% of all infectious disease, and we have 700,000 deaths per year. And we know that 80% of the world population is at risk for at least one vector-borne disease. Here we see the trend of this global exposure of vector-borne diseases. So this is, sorry. So you see that this is like 100 years, and the last episode there is 20 years. So we see how the vectors are increasing and expanding. For like in the last 20 years, it's a lot more than in the whole 100 years. So also climate and environment can affect the vector-borne diseases. So climate impacts like the heat waves, the rainfall, the droughts, they affect the vector survival and the habitats. And environmental factors like urbanization or agriculture or water systems, they all affect like the breeding sites. So again, we see that everything is connected through this One Health approach. And we are focusing on the West Nile virus. It was first identified in 1937 in the West Nile region. It is transferred by the Culex mosquitoes, And we don't have any treatment or vaccines yet. It is mostly asymptomatic, but in like 1% of cases, it can get to fatal encephalitis. And this is how it is transmitted, the cycles. So mosquitoes and birds are actually infecting each other. This is their cycles. But we have spillovers to human and horses, and they're like dead-end hosts. So humans and horses are not like transmitting forward, just it ends with them. But the mosquitoes and birds are like transferred from one another. So actually the first West Nile virus outbreak was here in Israel in the 1950s. It was in Mayan Tzvi. And Israeli researchers were among the first to identify that the human cases are connected to the mosquitoes. So since then, Israel have a lot of research in this topic. And this is very interesting. This was the first outbreak in the US. It was in 1999. So there was an unusual bird mortality, and it appeared even before the human cases happened. And the interesting thing is that this amazing woman, Dr. Tracy McNamara, I always like finding out about women that they are great. So apparently she was the veterinary at the zoo there, and she noticed that a lot of birds had died also inside the zoo. And she started doing her research, and eventually, after being like, no, it's not like this, eventually she got them persuaded that this was actually a West Nile virus that came from the birds. So this was the first time that the connection was made between the birds and humans. So it's really interesting. And it really highlighted the cross-species surveillance. It was a defining One Health moment. So it's a really good story. I'll have, there's a YouTube here of her, an interview with her, but maybe I'll do it later if we'll have time. So in the United States, we see on top, the maps on top, that this is like in the 2000s, so 1 year after, we see it in the New York area, the virus spreads. And then in 2011, it is spreading more and more, and this is 2023. So it is spreading around the US, and here in the bottom map, you can see how it spreads around the world. So the green are the vector, the West Nile virus. So it is in the US, it's in Africa, it's in Australia, in Europe, in Asia. Yeah. And coming back to Israel, so we know that there is a rapid warming. We have here the kulex. There are diverse habitats that help the mosquito to spread. And also important about Israel is that it is a bird migration corridor. So a lot of birds, migrating birds, are flying through Israel, from Europe, from Asia to Africa. So through the years, we can see that we had a few outbreaks, but two of them were really big. One of them in 2000, we had 400 cases and 40 deaths. And it was actually following a year of geese. Lots of geese died. Yeah. So and in 2024, just last year, we had the biggest outbreak we had 902 cases and 74 deaths. And it was the biggest that we've known. And it has a few reasons for it. So it wasn't just one factor reason. It has multiple factors. So first of all, there was an infrastructure event. There was a wastewater treatment plant malfunction. It happened in Ramat HaSharon. So really the whole area of the center of Israel got infected. Actually, even in my neighborhood, we had people actually died from it. But also, the climate conditions. It was early spring heat, more than usual, and also there was unusual rain before it in the springtime. So it helped. And also, it was from an ecological timing. It was right after the migration of the birds. So this is also like highlighting the need for the One Health approach to do. Yeah. And this is just to show us that the climate affects each level of the cycle of, like, it affects the birds and also the mosquitoes and also the human, and the transmission is affected. So in order to do this One Health project, we actually need a lot of data. So we need the vector surveillance that we will have to take from the Ministry of Health, the entomology lab, and human cases from the Ministry of Health. And for the animal hosts, we will have to get it from the Veterinary Institute and the Ministry of Environmental Protection. And all the data of the climate and environmental data, it's from the climate models and GIS and remote sensing and land use and a lot of places that we need to take the data from. And it's not that easy. There are a few challenges and dilemmas around it. First of all, getting the data from all kinds of parties is not that easy. And there are gaps, and also in the surveillance of the mosquitoes and the birds, it's not consistent always. So there are a lot of dilemmas that we need to handle in the data analysis. So in order to do that, we need this multidisciplinary One Health team that I am very privileged to have as my supervisor. So Maya Negev is from the environmental health and policy and One Health, and Professor Livne is from epidemiology and public health, and Noga Kornfeld-Shor, which is from ecology and environmental physiology and also zoology, and Dr. Asaf Hochman, which is a climate expertise. So I would have to put them all together. And so what we expect to have from this project is, first of all, to enhance our understanding, to clarify how climate and environmental drivers affect the West Nile virus transmission. We will also want to do a risk prediction to identify the high-risk areas and timing for the intervention. And we would like to have maybe an early warning system to develop for predictive models for the outbreak prevention. And this is actually filling gaps from that were already identified in the Israel's National Preparedness Plan for climate change adaptation. So we will have to use a few analytic frameworks like spatial analysis with GIS mapping, and statistical modeling, of course, with regression models, and temporal patterns with time series analysis, and of course the predictive modeling that we will use in maybe a machine learning or disease niche models. We will have to think about it along the way, what fits us the most. And these are examples from around the world of predictive models that already made this. Something like it from maybe other viruses, or they all like focuses on different climatic vectors or different variables, but it is definitely something that we can look and learn from. And policy implications like surveillance systems, like vaccination policy, environmental management, and community engagement that we can produce from it. And so, as we saw, addressing the vector-borne diseases in this change in climate, it requires the integrated action across health, veterinary environment, and climate science sectors. And so by applying this One Health framework to the West Nile fever, this research aimed to support more effective public health strategies and contribute to climate adaptation efforts in the Eastern Mediterranean region. Thank you.
Can you hear me, or do we need? I think we're right. Okay. So we're going to leave it here.
Wow, what a great team, powerful women. So the question is actually for Shelly, but I think it will be relevant to all of you. Especially Shelly, you finished with a regional perspective, but on the other hand, it was very Israeli. So there were outbreaks in Gaza during the war. I'm also aware of previous outbreaks of West Nile in Gaza years ago. And I wonder, of course it's very hard, but I think it's possible. You have contact with Arava Institute and other Ecopeace and other that you can consider. By the way, some of us participated in, was it January 2020, in a regional meeting with people from Lebanon, Jordan, Palestinians, and we were in North Italy, and COVID was already there for sure, we know now, but we just heard about something strange, but it was there. So I wonder about this regional perspective that is relevant to all of you, including Malawi. I don't know what is the connection in adjacent countries. And maybe it's a larger question that at least Natan and I are very interested now in health diplomacy and also Dorit and others and stuff. So I'm bringing this issue, so it's more for you, but I'll be happy to hear other people's perspective about the regional aspect, the health diplomacy, because in many of these places, I'm sure also in Malawi, there are probably tensions regarding different groups. Thank you.
We might use also data from other regions, and it's interesting about Gaza. I will look for it, and so but in the end, if we want to do that, like this model, we would like it to like that other parts can use it also. Of course, it will have to be changed with the area, and it's like different variables for each area. But I think this is the purpose.
Thank you, Nadav, for this question. So, as I said in my talk, cyclones affected not only Malawi, but also neighboring countries like Mozambique, Zambia, Madagascar. And one of the things that we saw is that the cholera outbreak lasted in these countries as well for longer periods of more than 2 years. And one thing that came from interviewing healthcare providers, especially across the border with Mozambique, is that different countries have different definition for cholera outbreak. So in Malawi, they only need one case to declare an outbreak, while in Mozambique, when you just cross the border, and you can cross the border without stopping in a checkpoint, because most of the people cross informally. Me myself, no, I need a visa. But others that live in these areas, they cross the border daily without having to stop at the checkpoint. And in Mozambique, the definition for an outbreak is about 5 to 10 cases. And we know that if we already have 5 to 10 cases of cholera, it means that we probably have at least one village that is heavily infected with cholera. And it makes things very difficult to contain, especially when we have this cross-borders movement and without the structures and the communication that is needed to contain the disease together. And I said that there are efforts to improve it, but it is easier in countries that share similar languages, like Malawi and Zambia, for example. But in Mozambique, they speak Portuguese, for example, and in Malawi, English is one of the formal languages, so it makes it very hard to collaborate across different languages and different definitions for outbreaks. So I think that one of the things that we can maybe learn from these case studies is how we can create clear definitions for hazards, clear definitions for outbreaks that are cross borders and are more universal. Yeah, thank you.
Hi, thank you for the question. I just wanted to add that, as we all know, climate change is what's called a nasty problem, that it doesn't have one solution, and it's very, very complex. And as Maya showed in her presentation, the first 2 slides, I think that the global north has a responsibility to help the global south. So in the Israeli context. So I'm sure that Israel has a lot of responsibility to what's happening in Gaza, and we have to make sure that together with our responsibility to what happens in where we operate, that we won't forget the peripheral areas, the Gaza, and we know that the diseases doesn't know any borders, so we have to make sure that the solutions that we bring to Israel, that it will serve the whole area and not only Israel.
Thank you. Wonderful session. We're really happy that we are here with our students, and each and every one is taking home some messages. I have many questions, but only two of you. Shelly, not a question. I wanted to really thank you for mentioning Stacy McNamara, my friend. I worked with her in the Bronx Zoo, where she was the vet, and I was just telling Stav before you said, I mean, really, it's amazing to see that you reminded her. I sent a photo, so thank you very much for that. And Shahar, thank you also for the cholera. And as you just mentioned, many countries do not report on cholera outbreak timely. And one of them, for example, is in Ethiopia. In 2017, I was heading the Ethiopia outbreak in that part of the world, managing the countermeasures to that. And the Ethiopian government really ignored us. She said this is acute watery diarrhea, no cholera. This is the nickname for cholera, acute watery diarrhea. We had the same in Tajikistan, no cholera. But my thing, you know, one of the things that I think it's very important, once you have one case, it means that the Vibrio cholera is in the region. It's there. And everything has to be done in prevention, because the activities, it's not enough preparedness. Prevention is a key here, and there is a clear strategy of WHO how to do it and who needs to do it. And here we are talking also about the oral vaccines and others that are very important. So I just wanted to add that dimension, which you did already, but thank you so much. So no questions, I just wanted to lecture. Thank you.
Okay, so again, thank you so much to all of you. Wonderful presentations. Just to add another thought to what Nadav mentioned, and you all kind of already started to discuss, if we try to apply a regional thinking to all the problems that were kind of discussed here, I think we also have to acknowledge the issue of gaps in data. I mean, Israel, for example, is a data-rich environment, and the countries surrounding it are not necessarily have the same data and infrastructure. So this is kind of a really strong barrier to apply, and this is something Maya and I and Alix are just now trying to develop a research proposal exactly about this, how to deal with such a problem. So I'm happy to hear your thoughts about this also, and thank you.
Yeah, it's a great question, because much of the research on climate change and health is conducted in the global north. That's where they have health data and resource to do the research. But it's not done where people are most impacted, because there is no data or infrastructure or resources in Malawi, sorry. You said that the health expenditure is $33 per person per? $40 a year. Including donor money, $40 a year for health expenditure. So obviously there is no data health registry that we can in the same quality. No, but yeah, I said in the same quality, of course. Yes, yes, of course. So maybe we can even study from it sometimes. I'm saying that I think we can be creative, so we can use proxies. Sometimes even Google Trends can be used for symptoms, qualitative research, because people know the best how they feel, interviews with policymakers, potentially AI and machine learning, of course not to rely on them blindly, but maybe these new tools can also close data gaps. And I just want to mention the global burden of disease database the first global maps that I showed. It's existed for almost 30 years, and it has every country in the world has data for over 3,000 health indicators. And their approach is that if there is no data, there is no problem. So every country, even the most rural, health data poor country, they have their algorithms and data collections to give a proxy. So if we have no reliable data, we should always find a proxy, because otherwise we're just not aware of the problem, and then we cannot act.
And another thing that I think is also important, especially, and I'm very happy that the master's students are here today with us, is that sometimes we just need to go back to the basic. And when we speak about emergency response, we know that there are several things that are repeating themselves. Right now, in Southeast Asia, there are, I think, almost 1,000 people who died as a result of the tropical storms that hit Sri Lanka and Thailand and neighboring countries. And I don't need a lot of data to just predict that are going to be an increase in infection with dengue, with malaria, with cholera. And to counter these problems, we need better health systems that can manage these outbreaks, that can contain different risks and hazards. So it always goes back to the basic of how we strengthen our systems to be more resilient and be able to combat different hazards, whether if it is dengue or cholera or heat-related illness. And I think that this is something that you spoke about it in your lecture about all hazards. And data is important, but there is a lot of that we already know and we still do not operate. So I suggest that we will start operate and collect more data, and it's obviously very important, but we need to mitigate, I think, the gaps between what we already know and what we do in practice. Thank you.
Thank you very much, everyone, for your amazing presentations. It's very good to have a synergy of the talk about climate and health-related diseases, and also the bridging the gap, just the synergy of the diseases, the challenges on ground, and how to get to solutions, meaning the way forward to everything that you all discussed. I have a question for Maya and Shahar, but I'd like your thoughts on everything. I didn't quite get why there was an oversampling of the Arab population. I'm guessing it's for a better representation of the data, but you could clarify that. And also if you accounted for that in some of the findings that you shared from the survey. And Shahar, you talked about how in Malawi the problem is evident, there's even involvement of the community chiefs and all of that in providing solutions, but you talked about health financing and how there's like NGOs funding the solutions, and I just wonder why for years the issue is evident, but then the health financing pillar of the health financing is always a challenge. So sustainability, bringing sustainability to solutions, what can we do exactly to bring health policymakers to see that this is what is on ground and this is how we need you to come in and, like own some of the solutions? What do you all think about this?
Thank you, Yemi. So the oversampling of the minority population, basically minority populations are more vulnerable to climate change because of a lot of indicators. In the Israeli case, the Arab minority is vulnerable, first of all, because it has lower socio-economic conditions and often other lower social indicators. Second of all, especially in the Negev desert, they live in very fragile conditions. So, I mean, there are recognized and unrecognized towns and villages, and the unrecognized, as I said, they have no infrastructure, no connection to the grid, etc. So they are particularly vulnerable to climate hazards. And that's why we oversample them in order to understand this population better. If we would just do a national sample, we would have very few participants from this community, and we wouldn't have enough power to do the statistics and understand what's significant about their characteristics, and that's why we did that.
So the sad reality is that it is easier to raise money when you have floods. People around the world, when they see a human catastrophe, it is easier for them to open the wallet and donate. And when we try to shift this paradigm for supporting preparedness, for supporting resilience, it is much more harder, especially with the changing in the aid landscape around the world after the disseminating of US aid, but also with other national agencies. I want to emphasize that healthcare in Malawi do transitioning to support better, and there is a learning from one cyclone to another, but as already mentioned, the resources are not enough. So we will have to prioritize. And the question is, which services are you going to prioritize, right?
Hi, thank you for a great talk, great set of talks. Maybe this is a naive question, but I'm wondering if you think we've learned anything from the COVID pandemic about data collection and about, you know, it did seem like over time a response evolved that was accepted more globally, that happened in multiple countries and so on. And I'm wondering if you think there are lessons that were learned that could be applied here.
Nadav should answer this.
Linda, we actually published this paper that is exactly on this question. We were also very frustrated how relative, I mean, of course, COVID is not perfect, but it was very quick, or at least it was easier to mobilize different, also outside the healthcare system, to join forces. In Israel, at least, especially because of, we need to say, Professor Noga Kronfeld-Shore, she used to be the chief scientist of the ministry, the collapsing Ministry of Environmental Protection. She also left, among many others. She's now at Tel Aviv University. But so for example, she developed a map of risks, both for heat waves and also for floods. So I think lots of this question is related to how different health in all policies and how different ministries create, especially on the mid-level, trust and a sense of solidarity among them to move forward in a time that, let's say, both in Israel and the United States, for example, some people there above are not exactly believing in science and or even in climate change, probably. So many good people are leaving, both in Israel and United States. I don't know about other countries. It's very sad, but some are staying, and some are really like the child with the finger in the Netherlands story. I'm sorry that I'm a bit.
For me, the COVID years were one of the most frustrating "we told you so" realities, because a lot of what we've seen during COVID, we've known from HIV and TB and malaria. A lot of the trends were familiar. And there were a lot of surprises that were not really surprises. I think for me, one of the most frustrating moments was when an Israeli scientist went on TV and said, when the one thing we learn about COVID-19 is that vulnerable populations are going to pay the price. It was like, oh my God. Did we really have to wait until 2020 to know that? We've known that, well, actually, during the years of the Black Death in the 14th century, it was documented that the poor people were suffering the most. And I think we have a problem with learning and sort of using the knowledge that we have as part of preparedness and adaptation. So I think we've made an immense leap during the COVID years as a proof of concept that when we want to collaborate, we can actually do an amazing job. And one of my kind of objectives as a teacher is to keep reminding us that we can do that when we put our minds to it. And I think this was a big lesson for me, that it is possible, but we have to hold on to it. And I come from the HIV world, and now we're seeing the backlash in HIV. And so we're about to forget a lot of very important lessons, and people are going to pay with their lives for us sort of moving on to do something else. And so I think and with climate, we have an opportunity to do it differently. So the question is, are we going to do that? And I have no answer, I'm afraid. I mean, in this room, obviously, everyone is committed, but I'm worried about what's happening in other rooms. Yeah.